to talk more on HIV, may we call on our second lecturer, Dr. Joan de Castro, and she'll talk about recognition and diagnosis of HIV among adolescents. I don't know if you're aware that HIV, unfortunately, in the Philippines is alarmingly increasing, and the most commonly involved age group, Diba Jo, is our adolescents, 15 years old to the early adults, 34 or 35 years old. So please welcome Dr. de Castro.
Good morning. First of all, I'd like to thank the organizing committee for inviting me to talk on one of my favorite topics. My topic is about recognition and diagnosis of HIV among the adolescents. By definition, when you say adolescents, according to the Department of Health, WHO, CDC, it is defined as age ranging from 10 to 19. But for the PPS, it's about 10 to 18 plus 354 days. So what's, okay. Now, the early and the middle adolescents, they are this stage where they are egocentric. They have this sense of invulnerability and a strong sense of experimentation. And probably that's the reason where they engage in risky behaviors, which makes them at risk of acquiring sexually transmitted infections, including the HIV. So as an outline, I'm going to talk a little about the burden of disease, the clinical manifestations which you see in the adolescent age group, how to diagnose, the treatment hubs that you can get, and something about what's new about HIV here in the Philippines, and the last would be the summary. So for the number of newly diagnosed cases with HIV per day, it has gone up to 26 in 2016. But actually, when I asked somebody from the DOH, it's actually 29 cases per day. And as to the data about the reported cases, from January of 1984 to December of 2016, it's actually 39,622, and 90% of them are asymptomatic. And 96% of these individuals are actually male. About 90%, or I'm sorry, 24% are between the ages of 15 to 24, and less than 1% are those less than 15 years old. As to the modes of transmission, there are several types. One is sexual transmission, but the sexual transmission can be divided into anal, vaginal, and oral sex. For the anal transmission, you have the insertive one and the receptive one, and it's the receptive one which has the highest risk of acquiring the HIV. Now, followed from the anal transmission, what comes next is vaginal transmission. And from January of 1984 to 2009, the mode of transmission is actually male to female. Beginning 2010, the trend has shifted to MSM, and it continues to be so until this time. For the modes of transmission among children and adolescents, majority of them are still MSM. And some of them are actually male to female sex. The others are having sex with both male and females, and some through IV drug users, and a little from mother to child transmission. In terms of the regions with the most number of reported cases, majority of them are from the NCR at 43%, followed by 4A at 14%, Region 7, 9%, Region 3 at 8%, Region 11 at 6%, and the rest of the country at 17%. The mode of transmission varies from region to region, like most of the MSM that has been reported are from the NCR. Most of the IV drug users are from Region 7, which is in Cebu. And most of the female who engage in transactional sex is actually from Region 3, which is somewhere in Angeles. Most adolescents, in 30 to 70% of the time, 2 to 6 weeks after HIV infection, develop this primary infection syndrome, or what you call the acute retroviral syndrome. And they manifest with sore throat, fever, myalgia, adenopathy, macular or maculopapular rash, and a fatigue, which is similar to your primary EBV infection. Now, for those age groups 6 to 21, those with AIDS-defining illnesses present with candida pneumonia, esophagitis, vaginitis, varicella zoster CMV retinitis, HIV wasting, MAI, cryptosporidiosis, severe herpes simplex recurrences, and even parotitis. So mostly from the herpes viridae family, okay? And of course, candida. Now, this is actually one data that I got from the clinical infectious disease. And those who were diagnosed at or preceding HIV tests for the age groups 8 to 19 presented with the following: recurrent sinusitis or upper respiratory tract infection, chronic diarrhea, tuberculosis, chronic skin conditions, oral candidiasis, shingles, esophageal candidiasis, recurrent pneumonia, other AIDS-defining diagnosis, and chronic HIV-related conditions, with the following CD4 count: less than 50, 50 to 200, and more than 200. Now, I got this from Dr. Aro, and I'm very thankful for sharing her data. This was actually a clinical, immunological, and demographic profile of children living with HIV in the Philippine setting. So this included children from 0 to 18 years of age. It's actually a retrospective multi-center study. So this involved PGH, RITM, San Lazaro. And in that study, there were about 28 individuals. And of these 28, 12 were adolescents. And the mode of transmission was MSM in 10, and 2 were from mother to child transmission. So that means to say they were born with the positive HIV from a positive HIV mother, and they became adolescents. Now, for the comorbid conditions, 45% of them have TB, a few had oral candidiasis, and some presented with chronic ear infection. So you will see that even from other countries, comparing this with our own data, we have TB and oral candidiasis. So some of the features that they presented were cough, probably because of TB, weight loss, also maybe from TB or HIV itself, diarrhea, skin lesions, chronic diarrhea, and oral thrush. And these are the PE findings with cervical lymphadenopathy, ear discharge, oral plaques, harsh breath sounds, hepatomegaly, pallor, and rashes. Now this one I just got yesterday. This was actually from the poster presentation. And this is a prevalence of HIV through clinically directed selective HIV screening in pediatric patients in PGH. So this is from 2011 to 2016. And this involved 126 individuals. Majority of them were 62 males. Males were majority of them, and females were 53 and MSM at 11. Now, of these 126, only 2 tested positive for HIV, and these were from the ages 13 to 18. Now, what they did was they used these 6 selected clinical features, and this is probably because of the resources, limited resources. So they just made use of these 6 selected clinical features, and they are tuberculosis, whether it's disseminated or extrapulmonary or miliary, or those who present with severe malnutrition, chronic diarrhea, severe recurrent respiratory tract infection, invasive pyogenic infection, and even oral candidiasis. So for these patients who present with, who were reactive for HIV, both of them presented with oral candidiasis, and only one presented with TB, disseminated TB. And for the risky behavior, both of them smoked, they drank maybe alcohol, they were also IV drug users, they used prohibited drugs, they have unprotected sexual contact, and they had more than 10 sexual partners. So 2 out of 126 makes about 1.6% prevalence during that time period. So these were presented from PGH. Now, I was also very fortunate, and I'm very thankful to Dr. Annie Di Tanco, who shared with me data in the RITM. So this is for the age group 18 years and below, and they also included the CD4 baseline, which was 7 to 2,768, and males, the exposure category were children born to HIV-infected mother, homosexuals with multiple sex partners, bisexual, homosexual partner of an HIV-infected individual, and even perinatal transmission. And for the females, it's a child born to an HIV-infected mother and heterosexual with multiple sex partners. Now, majority of these presented were asymptomatic, just like in the local data, the national data, and there were more males than females. Okay, so these were the AIDS-defining infections that were presented. Tuberculosis pulmonary, tuberculosis extrapulmonary, the PCP or your pneumocystis carinii pneumonia, candidiasis oropharyngeal, the pruritic papular eruption, wasting syndrome, oral thrush, candidiasis, urinary tract infection, and candidiasis of trachea, bronchi, or the lungs. These are some of the pictures which will show this is oral candidiasis, this is oral hairy leukoplakia, and this is your pruritic papular eruption. If you see patients who presents with rash, pay particular attention to the site. So this will be on the shoulders, on the face, at the back, or even the front or the chest, and even the hands. But not just the rashes, but you also take note of the other conditions like, I cannot read. Okay, like this one, fever, diarrhea, and etc. And of course, these are the rashes on the back, on the ankle, and on the chest. If you have risky behavior, ask if they are engaging in sex and they are using protective device like the condom. Now, the use of condom should be correct and it should be consistent. Hindi pwedeng once a week lang nagko-condom. It should be correctly inserted and consistently used. Now, if you have this risky behaviors, IV drug users, or those presenting with engaging in unprotected sex or even oral sex, or those who have histories of sexually transmitted infection, then you might need to suspect that since it's sexually transmitted, then the possibility of them contracting HIV is also there. So what do you do when you suspect them to have HIV? These are some of the tests that you can request for. There's a third generation antibody test. There's a fourth generation antibody antigen test, and there's a rapid test. The third generation antibody test is what we have right now, and what it tests are antibodies against the HIV. Now, there's also this window period, which is important because before you develop antibodies, it will take about 3 months. So if you test them during the window period, it might be negative. So you just need to retest them. So if you do this third generation antibody test, the time frame can be between 1 to 7 days before you get the result. But if you request for the rapid test, it's like within 20 minutes, you can get the results right away. Now, the reliability for your third generation antibody test is high. We also have the fourth generation antibody antigen test. So this time, aside from the antibodies, it also includes the antigen, which is your P24. Now, we don't have it right now, so what we have is the third generation antibody test. We also have the rapid test. And what we do right now is, because you have the screening test, this is your screening test. And there's also the confirmatory test. Now, for the rapid test, what they're doing right now is, if you have 2 positive rapid tests, then you can probably say that more likely this patient has HIV. But you have to take note of the specificity and the sensitivity. It has to be more than 95%, okay? And it's also important, but before you test these patients, you have to do counseling. This is actually mandated by law, that you have to do counseling and you have to get their consent. You cannot do the testing without their consent. So the law says that the consent has to be 18 and above for them to have the test. If they are below 18, then you have to get the consent of the parents. So this is actually the current HIV diagnostic testing. This is an algorithm for adults and infants who are more than 18 months of age. You have a different test for those who are less than 18 months of age. So once you are 18 months and above, it's just like you're doing tests also for the adults. So you do the screening test. This is either the rapid test or the enzyme immunoassay. And if it's reactive, then you refer that to the SACL. That's the reference lab for all the screening tests. Okay? So if it's non-reactive, then you report that as negative. But first, you have to consider also the possibility of the window period. If you do the test early on, and it's within the window period, it might test that the test might be negative. And therefore, you just need to repeat the test, especially if these individuals are engaging in unprotected sex or are doing, injecting drugs, okay, and sharing needles. Okay. So if they are referred to SACL, this is the time that they do the Western blot. But I think what they're doing right now is to be able to get some of these individuals who are afraid to undergo this testing, and they do the rapid test. As I said, 2 rapid tests will be almost equivalent to the Western blot. Okay? So as long as the sensitivity and the specificity of that test is 95% and above. So once the Western blot, once the Western blot is positive, then that person has the HIV. It doesn't mean that that patient has AIDS. It's just that they are positive for the HIV. So these are some of the baseline screening that you request for: RPR for syphilis, CBC, maybe to see if the patient has anemia, pallor, hepatitis B, chest x-ray, maybe to see if the patient also has comorbid tuberculosis, gene expert, maybe to find out if there's MDR-TB, and of course the CD4 test. We all know that if the CD4 test is less than 200, then that patient is likely to have AIDS-defining or opportunistic infections. Now, once they are tested, once they are reactive for the screening test and the Western blot, you can refer them to treatment hubs. And the good news is that we have several treatment hubs available. This is the treatment hub, this is the address, and this is the telephone number. So we have in NCR, we have also in Cebu, or in Visayas and Mindanao. So you don't have to refer them if you are in Visayas or Mindanao. You don't have to refer them to Manila because we have different treatment hubs. So when you have the treatment hubs, they also do free testing, and they give free medications. So these are your treatment hubs. You also have satellite treatment hubs and the other facilities available. Now what's new? They did the pilot study, the DOH, they did the pilot study. They started it last year, and they involved 3 public schools in Colyat, Commonwealth, and Batasan. And what they did was they incorporated HIV education in the K-12 curriculum, and it is in the MAPE. So MAPE is Music, Arts, PE, and Health, and this is during the first quarter, and they started it for those grade 8 and above. So grade 8 is like 14 years old.
First or second?
Oo, mga ganon. Okay. So this is something new. And the other one is, again, for the DOH, they also did this study, and this came out in October of 2016. And in that study, it's actually on the online social networking. So this, they found out that this contributes to the rise in HIV/AIDS cases. This involved 180 MSM respondents, and of these 180, 124 use online network sites for dating and sex. Now, I asked some personnel in the DOH, and they told me that the sites that they look for is the Grindr, the other one is Planet Romeo, and Facebook. So they meet in the they chat in this Facebook or the Grindr or the Planet Romeo, and they have this private meeting or private party in an exclusive subdivision. Or if you remember, there were some youths who died during this concert. So these people, I'm not saying everybody, but they engage in orgy, IV drug use, and MSM activity. Okay? 133 had sex with people they contacted through online network sites. And those who engage in sex were between the ages of 14 to 36 years of age. They can meet without fear of negative social consequences, And this use of internet increases the rates of risky behavior. So like not using condoms, they had multiple sex partners or MSM, and even IV drug use. So this just came out last year. So in summary, I've presented to you data, our local data on HIV among the adolescents. And those risky behaviors identified were MSM, IV drug use, and transactional sex. For diagnostic purposes, we have screening tests. We use the third generation antibody test, and this third generation antibody test you can get in a day's time or two. Now there are also rapid tests, like in 20 minutes you can get it, and that can supersede the Western blot if you have a positive test for twice or thrice, for as long as the specificity and the sensitivity is 95%. So with that, I'd like to say thank you very much for listening.